I've been very fortunate to have been involved in the early stages of AI introduction with OCT. So I'm going to talk about the use of AI and the imaging workflow and how it can impact on our approaches to PCI. These are my disclosures. So, well, we've come a long way, haven't we? 1977 and angiography-guided PCI. And then in the last couple of decades, I think we've seen an increasing use of intravascular imaging. Still with low penetration, but I think the higher resolution of OCT is encouraging us all to adopt it. Now, AI-driven PCI, I think, is going to drive that adoption even further, and really coupling advances in computing technology, machine learning, integrating that with our most loved intravascular imaging system, I think it really is a very tantalizing glimpse into the future. So the first applications of AI with the Ultron One software have been in the automated detection of calcium. And so applying this technology to the case that we've just seen has in fact delivers the information that you're making your choice of your calcium modification based on the arc of calcium and the depth of calcium. But of course, the mainstay of decision making is EEL guided stenting, and really the Ultron system really does deliver on that with instant access to a total vessel EEL profile. And of course, it has been integrated into the co-registration system. So I think that it was already a very strong system with AptiView, but the Ultron system with co-registration and AI in addition, I think is even more powerful. So we've heard about the simplification of workflow and MLD Max. I think we're going to become increasingly familiar with this way of working. Essentially, it boils down to what do I want to do? So make a measurement beforehand, assess the morphology and the sizing. And then once you've done what you were planning to do, does anything else need to be done once you've checked it? So this is really the workflow, and every case can be fitted into this workflow. And the AI really does facilitate the speed and efficiency of how we're working. So, sorry about the juddery image here. This is a straightforward case, a 70-year-old gentleman with chest pain who's been seen in the outpatient department. He's had a pre-procedural image with imaging with MRI and has got evidence of anteroapical ischemia. So the first shot here of his LAD shows that he's got a lesion within the proximal mid-vessel extending into the distal vessel. And certainly I want to get more information using intravascular imaging. So my next step after the preliminary angiographic images are going to be OCT. So we're doing an OCT, and all images, we're now trying to do the co-registration. It's a very simple system. Just compared to AptiView, there are a few differences. We're just plotting 2 points from proximal to distal. And you do your co-registration, and it gives you you answer the questions. Have we covered the lesion? Yes, we have. Is the study quality sufficient? Hopefully, I think this one is a sufficient quality study. So we're going to move on to our first inspection of what this vessel looks like to start our planning for stent length, stent size, what segments we're actually going to stent. So I tend to go with my morphology first inspection run. I just press the play button at the top here, and I just go through the vessel, and I'm noting all the different areas of the vessel. So currently we're in the proximal segment of the LAD. You may have noticed as we went down, there's actually a significant osteal lesion. We're getting into the tighter segment now. There's not really a lot of calcium here. The AI calcium detection algorithm, there's a little bit here appearing just at that LAD diagonal bifurcation, not something that's necessarily requiring a calcium modification strategy. I'm already now getting into the distal vessel, probably approaching where I'm going to be landing my stent. So, but at this very first inspection, the question I'm asking really is, do I need calcium modification? And the answer from this first inspection is no. So this is a non-calcium modification case. So what am I going to do next? Well, I'm going to carry on with my morphology, a slightly more detailed look at morphology. And what you can do on the longitudinal view is you can just click on it and you can click to the areas of interest, and I can start to get an idea of where I'm going to land my proximal stent and my distal stent. Now, I've got an area at the ostium of the LAD, which I'm concerned about. Those you may have noticed when we did the initial inspection that there is a significant lesion at the ostium. You can see it here. The questions that I've therefore have to answer at this stage are there suitable landing zones proximally and distally? And the answer from this initial morphology inspection is yes. So I move from the morphology part of this program to sizing. So we'll go to the next slide. So we click onto the sizing icon at the top here. And so what we're doing now is deciding on the detection of the external elastic lamina for the first stent. This isn't a lesion that I could treat just with one stent. We do have 48 millimeter stents in the UK, but this lesion is longer than 48. So this is going to be a 2-stent strategy for the LAD. And what I'm doing now is trying to find my distal landing zone. So I'm liking this, and I'm fixing on this point because it's above 3. So it means I can comfortably select a 3 millimeter stent distally. And then, well, I'm not going to use the 48, but I'm going to use the next longest one, which is going to be a 38. So I switch to the sizing view, and this is really the beauty now of the AI system. So distally, the readout here is 3 millimeters and a 38 millimeter stent. So the stent one, can the AI detect the landing zones and what is the size? Well, the size here is a 338. So stent one, we've got the size. Once that plan is in place, now that decision, we've taken a lot more time to make those decisions than it actually took in practice, because the AI gives you the EEL measurements immediately. So let's check what we've done. It actually looks good angiographically. Of course, angiography remains important. So the questions initially, once you've done this with your co-registered view, are there any angiographic concerns? Does anything jump out at you? Well, actually, it looks quite nice angiographically, so no concerns. So in the workflow, remember, we're looking for medial dissection, apposition, and expansion. There's no dissection, and yes, there is good apposition. Very clearly seen as we scroll through. So then we're looking at expansion. Of course, expansion is really the key parameter. Do we have full expansion? Well, in this case, just looking at this proximal segment, we've got 100% expansion. The time that this case took was really relatively short. We were just using OCT and angio for guidance. We weren't taking lots of other images. So all of the measurements were derived from that very first OCT run, and it was really executed very quickly with no need for calcium modification. And so what AI has done here has enabled us to implement the MLD Max workflow and integrate the key components of the artificial intelligence guidance system. We've detected the EEL, we've detected the calcium, in this case not much calcium. We've used the AI measurements to guide our stent and balloon choices, and we've had an AI-guided case review. So this type of case, I think, can be done. Every case could be done in this way. And it's a straightforward piece of software that it really integrates very well to make a very intuitive workflow. I think it's more efficient, and I think it completely removes the guesswork that we have when we're looking at the EEL. This is the first generation of this software, and I think it's really a fantastic starting point. So I'm very hopeful with the next generation, Ultron 2 and 3 and 4, as they come out over the following years. So at that point, I'll hand back to you, Kevin.
That was great, Jonathan. Thanks for taking us through that. We actually don't have Ultron yet in our center, so when I see you go through this in detail, we're excited for it, because I think, you know, as I alluded to earlier, the goal is to make this simplified and a tool which makes us more efficient so we can more easily do a high fidelity job. And I think these types of decision support tools that take a little bit of the guesswork or a little bit of the need for training out of it, such that the computer helps you to survey the artery quickly and understand where the points are that need to be addressed, is really wonderful. How many cases have you done now? I mean, you talk through it so quickly as if it's second nature already. Was there much of a learning curve to do this or to move from AptiView, or was it second nature?
I think there was a little learning curve. I think probably a dozen or so cases, but we've become very familiar with it. I mean, we're clearly, the people who've been using it have been relatively high volume users and familiar with AptiView. So there is a little bit of getting used to a new type of software, but I think it's really it's in terms of achieving the integration of AI, it's actually succeeded, I think, more than the expectations I think that we had initially. It's removed some of the functionality of the very advanced AptiView system with some of the 3D functionality, but I think what it's done is it's distilled the information down to absolutely the most important key information that makes a difference to the case outcome. So the external elastic laminar sizing delivered in this way, I think, is the game changer. The calcium modification, I think, is also, as you've already alluded to within the Light Lab project, calcium modification, I think, is going to become, you know, around 10 to 15% of our cases are going to involve some form of calcium modification. And I would suggest that, you know, a significant proportion of that will probably be intravascular lithotripsy in combination with some form of atherectomy. So I think as a starting point, it's great, but I think we've got to I think work hard to integrate it, not just for the ad hoc cases, but really as a everyday part of the workflow. I'm a firm believer in everyday OCT, that everybody deserves precision guided PCI, that if you've got a tool that can make a case, you can do a case more accurately, then you should use it.
Yeah, we've taken the same approach, and, you know, it's come a long way from years ago when I would ask for an OCT catheter on call for a STEMI to the fact that now it gets put in the room and the team expects it. Because I think, you know, for everyday purpose in complex PCI, calcium, ACS, it's really straightforward, and it informs us to be able to make the right decisions, get the stent in appropriately, and I think make sure that we've got a durable result for our patients.
That was an amazing case, as, quote, simple as it looked. But let me just tell you, you know, we have not beaten the Lima in any randomized trial, and that's because we haven't evolved and done better PCI. It's not that we need better stents. It's not that we need, you know, better operators. We need to do the cases like Jonathan did. There is no way that a Lima is better than that LAD, you know, fix there. So, you know, if we all adopt the strategies to get a good result, I don't care if we spend an extra 7 minutes doing the case. The guy spent 70 years before he got there. You know, maybe we can invest 7 minutes of time trying to do a good job. And there we aren't going to be able to make better decisions unless we get the information. And the OCT, informs us better than the angiogram has. We know that. So I think as a community, if we endeavor to do cases like this and not have restenosis, not have our patients suffer the penalty, we have to use all the tools available to us. And it seems like, automating a lot of the things that require thinking in 3 or 4 dimensions, and when dimensions, I mean factors, the AI approach seems to be something that's really a step forward.
Yeah, and I think one of the nice things which looks cool about Ultron is, people like you, me, and Jonathan almost have to unlearn our prior software interface, which we're very comfortable with, and approach something different. So this looks like for a new user who's never approached it before, who sort of is a clean slate, for lack of a better word, it's going to be a really nice and easy entree because the workflow follows MLD Max in a way where we plan our cases, which is wonderful. Duane, do you have any closing thoughts as we get to the end of the hour here?
No, I think it was just a really great, closing to see what's coming, with Jonathan's work and AI. I think, Kevin, your ideas that we have taken from Light Lab should be disseminated. But, I do think we have a panel of a coalition of the willing, and we're really talking about, things that are how we're expanding what we're doing. But, I just got a phone call from one of our physicians that does cases in the community and does cases with us. And because of what he's seen with us, he's adopted imaging more frequently in his usual lab. And his partners were looking at him like he had 3 heads when he imaged during a STEMI. And I think, we have to just preach the word. We have to say that, there are things that we can do better, and we can make better decisions if we have better information. But, very often people say, I don't believe in OCT or IBIS, and that's because they don't really know what they're looking at. And it's up to us to remove those barriers, because I will speak from personal experience is that I was one of those people. And knowing what I'm looking at, learning from you and others, Kevin, it's really transformed my practice. And as a consequence, it's transforming our laboratory.
And it's nice, all it takes is one physician champion to sort of get on board, and it's really neat to see how fast the fire spreads in this scenario. So how about your partners, Jonathan? Is everybody in, or is there practice variation among the people who you work with in your center?
I think where I've seen the biggest adoption, so before I went to the Brompton, I was at King's College Hospital, was really in the fellows. So the fellows who've come through a program where OCT has been the sort of main modality of intravascular imaging, many of those fellows have gone on to set up their own practices in other hospitals, and many of them are not quite approaching a sort of universal OCT adoption, but a significant percentage of cases, 50 to 60% of their cases being OCT guided, and implementing an MLD Max workflow. So I think that my hope really lies in that widespread adoption will come when we are educating fellows as a routine part of every interventional fellowship, that we don't treat imaging as an exception, but rather as a rule. And I think if that is embedded in people from the outset of their training for the fellows, and also I think for the non-physicians, the allied health professionals, when you get the buy-in of the whole lab, then I think then everything flows more easily. We've certainly seen the excitement amongst our lab when we introduced the artificial intelligence guidance system, that all of the physiologists now are all operating the system. And in fact, a lot of the stent selection and sizing is actually done by the physiologists. We're just generating the images, they're seeing the measurements, and they get the stents off the shelf. I know that this this happens in Richard Schlofmitz's lab, that they are actually, a lot of their cases are, guided by the physiologists, the technicians selecting the sizes from the generated images.
Yeah, it's a really nice fulcrum and focal point to get your team engaged. That's where I think the future lies. I think we're going to be. Yeah. Wonderful. Well, this has been great, gentlemen. I think I echo Duane's point to his partner who goes to two places. Once you get used to doing these things, it's really hard to be in a scenario where you have to go back and you can't rely on the high fidelity information we use. So it's been a wonderful session. I appreciate having both of your expert insights. And again, we want to thank Abbott for hosting and for helping to give us tools in this space with make our jobs easier and make our patients safer. So thanks, everyone. And we look forward to future conversations around this topic. Be well.